Thank you, Tom, for this introduction. Thank you for the organizing committee, also Dirk for giving me the potential to share with you a lecture on ovarian cysts and cancer in pregnancy. But I will only do this after a short introduction, because after 15 years of IOTA research, IOTA is in fact everywhere. And I'm really convinced that this kind of research collaboration, international collaboration, is only possible due to a strong investment in human resources. So they set up a separate IOTA branch focusing on this. And Dirk would not be Dirk if he also has a strong interest in arts. And that's why another branch, in fact, supports Leuven-based artists. But, Dirk, there is more. You know, all IOTA people, and Dirk in particular, they are really oftenly away, and some of you may know, but Dirk at home has some donkeys. So sometimes it happens when he comes back that he doesn't find his donkeys anymore. So that's why he constructed a separate branch, also an IOTA branch, developing GPS tracking systems for his animals. So, a small detail, you can't read it from the back, but there is no monthly fee. And if you say Dirk, then you say Tom. If you say Tom, you say England. And they wanted to celebrate somewhere, so they had this island on the air contest. But the story is not finished yet. Because already at this stage, Dirk and his team are already thinking on the focus of next year on a new project. So I received this private picture of Dirk, which shows, in fact, the new research profile, which is the IOTA Easy Performance. They will launch a new IOTA series for ambitious cross-country pilots. So Dirk and Tom and all IOTA collaborations. In fact, I want to congratulate with all the work you have done the last 15 years, the huge amount of work you have done. We look forward to the future projects, including the IOTA on endometrial cancer. So that was one of my take-home messages. I was asked to have 3 more take-home messages here. The first one is that, especially for this audience, sonography, when it relates to ovarian cancer and ovarian cysts in pregnancy, that sonography is more important than tumor markers, that chemotherapy is possible during pregnancy, and that patients can be treated, but that an interdisciplinary approach is mandatory. This is the agenda I will go with you. I will first focus on ovarian cysts in early pregnancy, and I will share with you a profile of how to flowchart on how to treat these patients. I will deal with surgery and chemotherapy, both from an obstetrical point of view and a pediatric point of view. I will then deal with ovarian cancer. I will shortly emphasize on interdisciplinary approach, and surprise, surprise, I will tell you something about contraception. Most common in pregnancy are functional or benign cysts that can be found during ultrasound. Most of the times they include cysts from the corpus luteum, hemorrhagic cysts, follicular cysts, or large simple cysts. And the good news is that most of these cysts will resolve after 14 to 16 weeks. If a cyst persists after this period, a dermoid cyst is most commonly encountered. So according to the literature, these are the cysts that are most commonly found: functional, dermoid, serocystadenomas, mucinous cystadenoma, endometrioma, para-ovarian cyst, and in some cases it might be a malignant tumor. Researchers before us, also Dr. Han from our group, looked into the value of tumor markers in this population. And in fact, these tumor markers are less reliable, because we did find that CA125 increased mainly in the first trimester, up till 550 units per milliliter, and then afterwards there is a decline. But also, due to the pregnancy, ACG and alpha-fetoprotein are increased just by the pregnancy. So these are non-reliable tumor markers for germ cell tumors, which may be found in this patient population as well. Granulosa cell tumors, then inhibin and AMH can be detected, but unfortunately or at least they are not so common in this patient population. So the main message is from this that the tumor markers are not so reliable. I will not focus on this nice publication and on the ADNEX model, but I mainly think that what you within the IOTA group found in the non-pregnant population is probably also true in the pregnant population. Although you did not test it, probably we can hypothesize that the morphology of these cysts will basically not change so much due to the pregnancy. So I do believe that in most cases, the rules that you use for non-pregnant women can be used in pregnant women. This is then a bit the flowchart that we would propose for these adnexal masses. Of course, if the mass is symptomatic, then we need to give treatment, either surgery, medical, or a drainage. Even an asymptomatic mass, if there are benign features smaller than 5 centimeters, a wait-and-see policy can be maintained. If there's a high suspicion of malignancy, we propose to do an MRI to confirm and to do a staging and to proceed surgically further on. In the case the mass is indeterminate, in the first trimester, you may follow up. If it's persistent and benign, wait and follow up. In the other case, also do an MRI, the same for the second and the third trimester. So this is in a nutshell. We just published this recently, the flowchart for adnexal masses in pregnancy. What about surgery and chemotherapy, the obstetrical and the pediatric point of view? These slides I want to show you just in order to show you that we have a lot of experience on surgery in general and also cancer surgery. And the most important issue in order to maintain the fetal safety is the adequate oxygenation and the left lateral tilt position. And depending on the gestational age, there can be no fetal monitoring or there can be fetal monitoring, with monitoring of the fetus, which is sleeping, or with monitoring of the uterine contractions. Of course, if we deal with ovarian cancer, fetal monitoring as such is not possible. For ovarian cancer, laparoscopy is frequently necessary. Is it possible in pregnancy? We do believe it is. However, it's only published to be safe if the time period is limited, around 90 minutes, intra-abdominal pressure of not more than 10 to 13 millimeter quick, open laparoscopy, and an experienced surgeon is necessary. And doing so, the literature reports that laparoscopic surgery is possible until 26 to 28 weeks of gestational age. We all know that pregnancy as such is a vulnerable situation. We know that women who drink on a daily basis alcohol, that this will result in the fetal alcohol syndrome with cognitive impairment and also facial dysmorphia. And that is why we ask our women not to drink alcohol. The same is true for smoking. Smoking has a direct effect on the vascularization, and it results in intrauterine growth restriction, premature labor, and intrauterine death. And based on these, we actually ask our women not to smoke. So this patient is treated surgically for breast cancer, and she's now getting FAC chemotherapy, and nevertheless, she's laughing. So what I want to share with you in the next slides is what did we tell her in order to make her sure that chemotherapy was not so, did not have such a negative effect on the baby. Well, we shared with her the first outcome of our international registry dealing with congenital malformations. In red are the major malformations, in blue the minor malformations. Here are the treatment modalities: no treatment, surgery, chemotherapy, or a combination of these. And what you can already appreciate from the first sight is that the major malformations are in fact in a group that did not have chemotherapy. In the group with chemotherapy, there was one case of a hip subluxation and one rectal atresia as a major malformation. And rectal atresia is in fact one of the more common congenital malformations. The conclusion from this and other publications is that chemotherapy given after the first trimester does not lead to more and/or other malformations at birth. For obstetricians among you, this study that we did together with the German breast group focused into the obstetric complications. In fact, we did not see more obstetric complications. However, there was a tendency towards a difference in the groups between chemo and no chemotherapy, especially regarding intrauterine growth restriction, premature labor, and premature rupture of membranes. However, this needs to be confirmed, but nevertheless, it is a point of attention for obstetricians. There is a checklist that we published 3 years ago. I will not go into detail with all aspects, but I highlighted in red what is important for you. First of all, at the diagnosis, confirm the pregnancy and determine the gestational age. And before we start with any treatment, it is important to determine or to detect any congenital malformation in order to be able to draw this decision when any cytotoxic treatment is given. Also, when treatment is given, check for intrauterine growth restriction and do well the follow-up of the growth of the baby. What about the long-term outcome? The first publication was in 2012. I will share with you the most important outcome here and then an interim analysis we have done now. Despite the tendency towards an intrauterine growth restriction, smaller births or weights at birth, this slide shows, in fact, that the biometry for females and males regarding to weight, height, and head circumference is in fact normally, and it's well between the 5th and the 95th percentile. So these children who have a bit lower birth weight, in fact, they catch up during the first months after birth. We subsequently continue to follow up these children. At the left, you see Magali Verheke. She's sitting at the back, who is one of our PhD students doing ultrasonography of children exposed to chemotherapy. And Tineke is a psychologist who does the neurocognitive testings. And in our first paper, we did find, in fact, a correlation between the IQ score and pregnancy duration, in the sense that the IQ score increased with 2.5 points for each week increase in pregnancy duration. So we hypothesized that not chemotherapy, but that prematurity, in fact, led to a lower cognitive score. When children were older, we looked into the behavior, memory, and attention. The results are expressed in a Z-score, so everything what is between -1 and +1 is normal. And as you can appreciate, all the values are well within the normal limits. However, this study has several limitations. It was a heterogeneous group. The youngest child was 1.5 years, the oldest 18 years. We lacked a control group, and the follow-up time was rather short. So that's why we started a case control study, and we now, and I will report now on 108 children of mothers born out of mothers with cancer during pregnancy. The majority of them are from Belgium, 8 from the Netherlands, 8 from Italy. Of these 108, 80 mothers received chemotherapy. Testing was done at 18 months and 3 years. And we did do the Bailey scale of infant development, and we have a well-balanced control group. Cancer types, in fact, 5% of all these cancers were ovarian cancer, but the majority was, in fact, breast cancer. This is, in fact, the most important slide of my lecture because it reports, this is the interim analysis, the mental development in these 81 children. Here we see the chemotherapy-exposed children, and in orange is, in fact, the control group, and there is really no difference between these two groups. And when we compare the outcome with the number of cycles of chemotherapy, we see that there is no difference whether a child was exposed to 2 cycles of chemotherapy or to 6 or 7 cycles of chemotherapy. And then when we compare this with the slide from the previous publication, let's focus on this slide because this is only on the children receiving chemotherapy, and we again correlate the mental development index with the chemotherapy, with the gestational age. We see the same tendency, namely that prematurity leads to a worse mental development, but not chemotherapy, and that the effect in both groups is in fact the same. And Magali will confirm to you that regarding the cardiac data, especially in children who have been exposed to anthracyclines, which are cardiotoxic, there are in fact no congenital heart malformations, normal ECG, normal heart diameters, and normal systolic and diastolic functions. The clinical implications of these findings are threefold. We do believe that the fear for chemotherapy is no reason to terminate a pregnancy, that the fear for chemotherapy is no reason to delay maternal treatment, and that we should rather give chemotherapy in order to avoid prematurity, because prematurity as such is associated with an impaired cognitive development. I always like to share with you this slide because it really shows how healthy these children are and how happy these parents are. What is the main reason for this? The main reason is that the placenta is as such not a passive organ. The placenta contains receptors that in fact catch large molecules like chemotherapy drugs. In contrast, alcohol is a very small molecule. There are no receptors, and alcohol passes the placenta freely. About ovarian cancer, according to our international registration study, about 6% of all cases are in fact ovarian cancers, including borderline tumors. As you can see, the majority are in fact breast cancers. I will share with the next 5 or 6 slides the most important conclusions that we made during our second international consensus meeting that was published last year. Borderline tumors are most likely to be stage 1. I think I could show you that we can operate during pregnancy, so staging is possible. We can do a unilateral salpingo-oophorectomy or mantectomy, peritoneal biopsies, and take a cytology. Higher stages, the surgery or complete surgery is not possible, so there we propose to wait until after delivery. For early invasive cancer, we do believe that staging is possible, including lymphadenectomy with or without chemotherapy. For advanced stages, we have to say that the experience is limited, so the approach is still experimental, but in the motivated patients, we do believe that we can treat. If we treat, we should only take a biopsy because debulking surgery by definition is impossible because you cannot mobilize the pregnant uterus as such that the Douglas becomes really accessible and approachable, and the tumor can be resected there. So any debulking is expected to be incomplete, so we propose to do a biopsy, give chemotherapy, allow vaginal delivery, and then complete the treatment after delivery. Non-epithelial ovarian cancers can be diagnosed as well. Also, there is usually stage 1. The same principle, staging, surgical staging is possible, and depending on the type of germ cell tumor, chemotherapy or not can be recommended. This is an example of a patient with a solid ovarian mass. You can better than I do appreciate this. It was a solid ovarian mass, about 7 to 8 to 9 centimeters in diameter. We also did an MRI that showed tumor mass sharply delineated, lobulated, but no invasion of the surrounding tissues. Tumor markers were normal. We operated, we did a surgical staging. It appeared to be a stage 1, grade 1 dysgerminoma, not necessitating chemotherapy. The patient is doing well, and the pregnancy, in fact, developed normally. Just 2 slides for the interdisciplinary approach. It is obvious that not only oncologists but also perinatologists should be involved, obstetricians, especially when surgery is aimed for, especially when cesarean section is needed. For example, this is not ovarian cancer but cervical cancer, and we do believe that instead of the lower transverse incision, that in case of cervical cancer and in order to cut through the cervical tumor that may lead to wound recurrences, that it's better to do a corporeal incision. Also, any cesarean section is an opportunity for the oncologist to come along and to see whether or not any surgical approach during this procedure is of any benefit. This is a patient where at cesarean section we decided to combine the cesarean section with staging, and we did do a para-aortic lymphadenectomy. So by combining these, we do believe we offer the patient a benefit. So I promised you one interesting slide on contraception. This is a publication by Selene Han, one of our PhDs who defended her PhD and published in Lancet 2 months ago a letter to the editor on our international registry. And in fact, to make a long story short, we did find that 3% of our population in fact became pregnant during cancer diagnosis or during treatment. So the main message from this publication is that these young women with cancer, we should inform them on fertility preservation, but also we should talk about contraception. So I hope I made clear that sonography is more important than tumor markers when we deal with an ovarian mass during pregnancy, that chemotherapy during pregnancy is possible, and that an interdisciplinary approach is beneficial for the patients. We conduct this international network on cancer, infertility, and pregnancy. If you want to become, or if your center wants to become a member of the INSIP team, you're more than welcome to join us. I want to acknowledge my 2 institutions that support me, and I want to thank the institutions that pay the research we conduct. And last but not least, I want to thank the collaborators of our team. We have an obstetrician, we have a psychologist, Dr. Han is a gynecologist, we have an engineer, we have Magali, who is a gynecologist, we have a gynecologist from the Netherlands joining us, we have a fundraiser, we have administrative support, we have a case manager, and Marie is administrative support. So it's important that also within our team, this interdisciplinary approach is very important. Thank you very much.
Thank you, Frederic. I'm a bit disappointed that this INSIP group hasn't developed its own GPS and parachute system yet, but I suppose with time you'll begin to evolve. Any questions from the floor? I suppose obvious question, perhaps I missed it, was that you talked in general a lot about chemotherapy, but are there particular types of chemotherapy that you may amend or avoid, or is there a dose-response effect? I just wondered if you might want to comment on that.
I think that's an excellent question. I indeed focused on the chemotherapy because the chemotherapy is in fact very important because it adds to cancer treatment during pregnancy, and if you can give chemotherapy, you can open many other doors. So that is the reason why chemotherapy is a focus. Indeed, our results, we cannot generalize to all chemotherapy types. If we look into the types of chemotherapy, it is mainly chemotherapy used in hematologic cancers and in breast cancer. But for example, for gynecological cancers, the number of cases with long-term follow-up on cisplatin and on taxanes is not so long. So we have to take this more into consideration and go for a longer follow-up and more cases per type of chemotherapy.